Thank you for joining us on this very special pre-recorded webinar where I sit down and discuss the recent changes to the Strength and Aged Care Standards, but also the Support at Home program. Before we begin today's discussion, I'd just like to acknowledge the traditional owners on the land that we meet, the Whadjuk people from Noongar Nation, and pay respects to their elders past, present and emerging, and recognise their connection to land, waters and community. I'd also like to extend that to all the unique cultures of people that are watching this webinar today. Today, I am sitting down to discuss these changes with Catherine Spinney, who is the Program Officer for LDAC, End of Life Decisions in Aged Care for Ageing Australia. So please welcome Catherine.
Thanks, Tim, and it's lovely to be here. And look, there's been significant changes across the sector, so I'm happy to share some insights into those today, with obviously a specific focus on end of life and palliative care. I thought I would just start with just actually going through, I guess, the key changes, which I think has impacted the sector the most. And with particular focus, obviously the Aged Care Act in December 2024, the new act was introduced. And with this brought about a number of changes, in particular in relation to the strengthened aged care quality standards. It also changed quite a bit in the Support at Home program. It introduced a new end-of-life pathway funding stream, and it made some changes in residential care, but perhaps not as many as the home care sector. I also thought I would just touch on some of the LDAC resources which are available to anyone and everyone. They're free resources, they're evidence-based, and they are absolutely fantastic if people are providing care in end-of-life or palliative care. So I encourage people to certainly have a look at those resources at the end of this session. So moving forward, I think the first thing it's really important to talk about is the strengthened aged care quality standards. Now, for residential care, they have been used to being judged against the previous standards, and this is how they've actually had to regulate and comply for their funding. However, in home care, the standards are new. The home care has not had to comply with the standards previously. So this is a really new space for home care providers. In particular, when we're looking at end of life, we're looking at standard 3 and we're looking at standard 5. Now, standard 3 is all about the care services, the ones you are funded for, and standard 5 is about the actual clinical care. So I thought we'd kind of talk just through those two little areas today and how they actually link back to care provided in the home care space. So if you look at standard 3, standard 3 is really, in particular standard 3.1 is around advanced care planning. Now there's a lot more in standard 3, but this is the area obviously specific to end of life. And this talks about where the provider has to provide an environment or an opportunity for individuals and their family to discuss future medical treatment and care needs. It has to look at their goals and their preferences, obviously cultural and religious practices and traditions in relation to these. The provider also has to support the individual to complete and review an advanced care plan. I do note, however, and there's a little bit of confusion in the sector about this, advanced care planning is not compulsory. There is no regulatory requirement for a person to complete an advanced care plan. And you'll note here it says in the standards if and when they choose. So just to clarify that, because some providers have been under the impression that they actually have to, in some way enforce people to complete an advanced care plan. The other thing I think it's important in this standard to recognise is that we need to support individuals to nominate and involve a substitute decision maker if required in their care decisions. And again, within the Act, this is a section that has changed significantly. The definition of a substitute decision maker has changed. And I really encourage all your listeners, if they're in this space, to actually look at those changing definitions because it is quite complex and it does take a while to actually get your head around the different language they're using now, but what the role actually does involve. So, for example, they talk about formal and informal supporters now. And you need to understand the difference around that because they're quite differing roles. And I think the final bullet point within this standard is that we have to ensure that advanced care planning documents obviously are stored appropriately, but also that relevant parties have access to them. So, for example, in a home care environment, where is the advanced care plan going to be kept? If an ambulance is called, how do the paramedics know there is an advanced care plan? How does that go with the person to the hospital, for example? So it's all these kind of things we need to think about. And this is why caring for someone at end of life in a home care situation can be quite different from a residential care situation, where perhaps when a person goes to hospital, we have all the paperwork ready to go with them. And that certainly has been my experience. So I guess just to be mindful of those type of situations is really, really important. When we start to look at standard 5.7, now this standard is specific to palliative and end-of-life care. And you can see that it has 4 particular actions that sit within this standard. The first one I say is about being prepared. So this is where a provider has to have systems and processes, policies in place that recognise when an individual does require palliative care or they are approaching their end of life, and that the provider is able to support them, obviously, to prepare for this experience and to be able to respond to their needs and preferences. So this is kind of the one that is about, does the person have an advanced care plan? Does the person have an advanced health directive? Do we have a procedure in place for caring for someone at end of life? Do we have appropriate assessment tools? Do we have access to a doctor, GPs who are going to come and support that person? So this is about the provider being prepared for all those possible scenarios. The second action is really around communication. It's all about making sure we communicate what's happening with the individual, with the family, with their substitute decision maker, that we're having lots of conversations, we're involving them in, healthcare decisions, we're doing end-of-life care planning, which is an important part of the new changes, and that we're really keeping those conversations open. It's also about how we communicate with our partners. So if we are working with a specialised palliative care service, what is that line of communication? What is our referral process? How do we connect with them, engage with them after hours, for example? So it's really about communication with all different parties that are actually involved in the end of life journey. The next action, or the third particular action, is actually about action. It's about doing something. So this is where the provider really uses, all its processes, all its procedures. It has a comprehensive care plan and it actually delivers the care. So it's all about how we manage symptoms, how we manage the environmental considerations. For example, if it's in a home care environment, do we have to get special equipment in? Do we have to look at modifications? What sort of other supports might the family need? So it's all about those kind of things. So it's really about that part where we're starting to care for the person at end of life. And really, the same goes for the fourth action in this particular standard. It's about that very end of life, that sort of imminent or active dying, and being prepared for the things that some of the crises perhaps, or the things that can go wrong. Symptoms can change very quickly. We want to try and minimize, hospitalizations if we can, but just kind of being able to be really responsive to end of life changes that sometimes can be quite unexpected and can happen very, very quickly. So really, standard 5.7, these are the 4 key actions. If you actually go to the standards, they give you some ideas around how you can meet these particular standards. And I think it's really worthwhile, if providers don't already have a really good framework in place, it's a good starting point to look at some of those suggestions and think, if I did A, then I'm actually meeting the first requirement under standard 5.7, for example. So it's a good starting point if you're not already quite advanced in that space of having your policies and procedures and linking them back to the actual standards. There's also some great resources that LDAC provide. As I said, they're free of charge, they're evidence-based. LDAC is funded by the government. We have 3 partnering universities on board. We also have some really experienced palliative care clinicians on the project. So if you're using LDAC resources, you actually know you're getting quality resources that are based in an Australian context and they're free of charge. And I think that's really important. The other thing is that the LDAC, all the resources are regularly reviewed and kept updated. So you're not getting something that's kind of done 10 years ago, 15 years ago. So everything, even this particular guide that they have developed around standard 5.7 was all designed around the strength and quality standards. So it's kind of, what you're getting in this is current to the changes in the sector. So the guide's a good place to start. Again, if you think, what do I need to do to meet standard 5.7 and standard 3.1? And for example, we have an LDAC care model. And really, if you look at the components of this particular care model, you can see that it will meet standard 3.1 and it also will meet standard 5.7. So some providers have very comprehensive clinical frameworks for end of life and palliative care, and some are just starting out. So this is a great framework. If you're just starting out, you can use the framework as is. If you're already quite advanced in the space, I would suggest you use the framework to perhaps audit or check yourself, because you'll notice with each domain of care, it really goes through that whole palliative and end of life process. And that's what I kind of like about it. It just tells you you've got to be thinking of advanced care planning. You've got to be thinking how you recognise or assess end of life. You've got to be thinking about when you perhaps need to introduce a specialist palliative care service. You've got to be thinking about how you're actually going to manage the active dying process, which is quite different to the beginning part of end of life. And of course, bereavement. There is a requirement that providers offer or certainly, provide some level of bereavement support, both prior to and after death. So I think it's a good place to start, and certainly to check yourself against the framework. It's actually an interactive framework. So if you click on any of the domains on the website, it takes you to a whole suite of resources, including some education. modules, and also some clinical tools, some auditing tools for those of you that perhaps work in the quality improvement space. So it's definitely worth having a look at that particular model and just taking what you want to use and leaving the rest behind. You are also able to use parts of the LDAC resources. They're not governed by copyright. So you might like a bit of a paragraph here of a fact sheet, or you might like a few survey points of a particular audit without using the whole audit. And that's fine as well. You can adopt the resources to suit your own needs. I just thought I'd show you, I think, a really useful resource as well, in particular around standard 5.7. We talked about how we need to assess changes, how we need to assess end of life, how we need to be really responsive to changes. And for example, if you click on the assessed palliative care needs, which is the domain of the model, what comes up is a whole list of common clinical tools. Now, a lot of providers already have used their own clinical tools in this space. What I like about this tool is it provides the most common ones, but the ones that are evidence-based, the ones that can be used in different circumstances, and it also gives you insight into who can use those tools. So when you're trying to sort of think, well, we've got this tool, but I wouldn't mind trying to complement it perhaps with another tool, this is a really good starting point. It also will tell you, if the tools are free of charge or you have to pay for them. So I think all that's just a little bit easier, to be honest, for providers if you're looking to sort of build up your toolkit, specifically around good end-of-life and palliative care assessment tools. This is a great starting point. It's also obviously, if you click on how to recognise dying, it clicks on some tools as well, which is also quite useful because that can be quite challenging in the home care environment to actually recognise someone is approaching or moving into end of life. Sometimes it's not as obvious, and there's some great screening tools that you can use as well in that space if you don't already have those tools. LDAC also has some what we call our toolkits. So again, there's 8 toolkits, and within each of these toolkits is a whole range of resources. Again, you've got fact sheets, you've got educational resources, you've got some auditing tools, you've got some clinical tools if it's relevant. And they're regularly updated. So obviously you can see there's a residential aged care toolkit, which is great. That's just been reviewed. I think it was literally reviewed a few months ago. So that's incorporated a lot of the changes. You've got the home care toolkit's just been reviewed currently. It's nearly completed. So again, that will incorporate all the new changes. The dementia toolkit's just been reviewed. Great toolkit. And also there's an end-of-life toolkit, which is regularly reviewed by the Faculty of Law at Queensland University. It's an amazing toolkit. And if you want to get your head around the changes to substitute decision maker and those types of things, go to the toolkit because they have broken this all down and from a legal perspective worked out exactly what you need to be mindful of. So there's some great info in the toolkits, and I would encourage everyone just to have a look and again take what is relevant to you or relevant to your service. Again, if you're to click on a toolkit, this is the type of thing that comes up on the website. And I just wanted to highlight the end of life law toolkit because I absolutely love it. And I just think every section in here is so relevant to aged care. But obviously advanced care directives, really good to know about those if you don't already. Substitute decision making, as I mentioned before, there's been some really key changes there. definitely worth having a look. And voluntary assisted dying, we're seeing an increase in the uptake of voluntary assisted dying. And I think it's just something that's, in particular in aged care, we need to be really aware of our responsibilities. And again, they differ between residential care and home care, and they differ between states. So definitely worth looking in that space and ensuring that, the people, your staff, but also as a provider organisation, you are meeting your requirements within that. So yeah, it's great. The other thing I really draw people's attention to is the person's right to withhold and withdraw from life-sustaining treatment. Often we'll see people, that don't want to eat or drink, and that can become for families quite problematic. But as a provider and as a service, we need to be respectful of that person's decision to perhaps stop eating, stop drinking, things like that. So it's really good to understand your rights, because that can be really hard for staff, especially when families are giving you some grief about it, or feeling that, dad should really be drinking and he doesn't want to, So it's things like that that helps you, but also helps you explain to the family around, the rights of the person to make these decisions. And hopefully, if they've done an advanced care directive, you don't have to have such hard conversations. But as we all know, the uptake of advanced care directives is pretty low in the aged care population, sadly. So that's sort of the standards, I guess, the main, changes to the standards and how that impacts the sector. Obviously, there's a lot more to it, but they're just the key points I think that are relevant. There's been significant changes to the home care program. And as I mentioned previously, the sector's really has been working hard over the last 12 months to get their head around the changes. The changes were meant to come into effect 1 July 2025, but that was delayed to 1 November. But now they're fully well in situ, and there are some big challenges for providers, in particular around funding and co-payments and lots of messiness like that, which I won't get into today. But obviously for them, the big change I mentioned, they now have to be compliant with the quality standards. They didn't before. There's some changes around care management, and that care management is about how they coordinate and case manage a client. So that's become a little bit different, and what they can do within that scope and what they can claim is different. There's also some changes around the supported home service list, which I will talk a little bit about. And there were some short-term funding pathways that were introduced, which is great. And one of those was the end-of-life pathway, which we'll also talk a little bit about today. That particular manual, if you've got nothing to do and you would like to do some reading, it's only about 450 odd pages, so please feel free. But I'll talk a little bit about the specific sections that are of relevance, I guess, in this particular space. So let's talk about the end-of-life pathway first, because this is very new and it's not without its, I guess, controversy. So, but we'll wait and see. The proof will be in the pudding as to whether it works. Look, it would be fair to say this was designed to support more people to die at home and to reduce the number of hospital admissions for end of life for people that don't want to die in hospital, because we need to recognise some people do want to die in hospital. That is their preference. So it's really was one of the reasons the government decided to fund this particular pathway. There is an eligibility criteria. So it is, you must have a medical practitioner, so your GP, or a nurse practitioner, must provide an estimated life expectancy of 3 months or less to live, and not all, and you must have a score of 40 or less of the Karnofsky measure. Now, the eligibility is problematic in itself because most home care providers do not have access to a nurse practitioner. Some do. And a lot of home care providers, because the client sees their own GP, there will be a number of GPs that will not be familiar with the end of life pathway and may not be comfortable signing off that the person has less than 3 months to live. The other issue that the sector has raised is around the Karnofsky measure being used as the eligibility criteria because it is not necessarily sensitive for different reasons to end of life. And I'm sure a lot of palliative care practitioners would speak to this. My understanding is, and I have not used the tool, but my understanding is that there may be people with a score less that are not at end of life and vice versa. So it's not necessarily sensitive to the changes that can indicate end of life. So that'll be interesting. We don't know how that's going to work. We do encourage providers perhaps to use another assessment themselves, another screening tool, or perhaps to just complement this as a double check before they sort of lodge paperwork and start accessing funding if they're unsure that the person meets the eligibility criteria. The government is committing $25,000 over a 12-week period. You can use this money for up to 16 weeks, but there is no more money. So if you run out of money in 9 weeks, the person reverts to their previous home support level. This is problematic if the person, for example, is on a level 2 or 3, that is significantly lower than the end of life pathway funding. If they're on a higher, like the old package 4 level, then they're going to perhaps be able to still have support. So, but the providers are really worried that if they run out of money or they don't perhaps budget the services according to the needs wisely, there could be a problem in funding. And it's been made very clear they cannot get an extension on the funding. So again, there's a little bit of concern around that, and people, I guess, are thinking outside the box how they might sort of try and work around that.
And Catherine, I'm right in saying that there's a fast-tracked pathway so that people that are assumed to be end of life can access these funds quicker. But in that scenario in which they would then revert back to their former package, if they live longer than those 16 weeks, then is there the option of them being assessed quicker, or would they revert back to their original package and then have to go through that whole waiting process again?
Good question, Tim. There's nothing written to say that they would then be prioritised. We would hope they would, but there is nothing that says they must be prioritised. I have heard from a couple of providers that registering someone from the pathway was very quick. It did happen within 48 hours, which was good for the sector to hear, but we haven't seen what might happen at the end of that yet. We're encouraging providers where possible. If someone is deteriorating, we encourage them to seek an urgent review of their level to get them on a higher level before activating the pathway, just to, I guess, as a buffer in case at the end they run out of money. But we really, to be honest, until we see some people go through this process, we just don't know how it's all going to pan out in the wash, to be honest.
Is there a sufficient enough number of providers in the home support space to cater for this anticipated increased demand?
Yeah, we did a survey few months ago now, and it was just a general survey. We had, I think at the time, about 170 providers on a webinar, and we just did a quick and a bit of a dirty survey on how many would provide end of life, how many were thinking about it, and how many would not. There was only about 10% that were definite nots, but there was about 27% that were unsure. So we found that really interesting. So really, that is a third of providers felt they weren't sure, and we don't know how many of those that third have since decided not to provide it. And so yeah, I think again we're just in the process of doing a new mapping project, which we will get a sense of the providers, hopefully that to get a sense of how many are going to do it. We feel there will be a number of providers that won't because they just may lack capacity and what is required, it just may not suit their circumstances depending where they're located, are they a standalone, all of that. If, for example, if you have very limited access to a specialist palliative care service, you have very little access to GPs, nurse practitioners, all of these things, you're going to struggle to make some of the requirements within the standards.
Mm.
It's a tough one. So how do you access it? Well, whether if you're a home care client already, then access would mostly be through your provider. However, people that are not already in the system can access it. When I spoke to a couple of providers, their referrals to date have come out of the acute sector. So it's actually been the hospital environment that are doing the referrals. And our sense is this could be more of the pathway than perhaps a provider simply trying to engage a GP to do it. So that'll also be interesting to see long term whether that changes. But it can be, as I said, for people already in the system or those that are not in the system. And as I mentioned before, they will be prioritised, and we have heard to date that those approvals have gone through within 48 hours. There's an end of life form which is available on the department's website, and the manual refers to that. It needs to be completed and submitted. It's a 2-page form. It's actually not that onerous considering, it's signing off on 3 months or less to live. But it is quite a basic sort of form, so that's good news for the GP and the nurse practitioner. And obviously, once that's submitted, the person must be assessed again through the aged care assessment process. And as I said, so far we've heard good reports. However, it's new. They don't have a backlog. There's no, they're not facing that yet, and I don't know whether they will, but it will be interesting to see if it continues to be a very fairly quick process. I thought also I would just touch on there's been some sort of queries in the sector around the residential care minutes as well, because this is something a bit new for the residential sector. And I guess, obviously they've always had to report on care minutes, but through the Royal Commission, there is now a requirement for an increase in those care minutes. So I thought I'd just touch on it briefly, but to be honest, just leave some more resources that interested listeners can go to these resources if this is something relevant to their service. Just to be clear, I think in the past it was about 200 care minutes, so it's increased to 215 care minutes per resident per quarter. And 44 minutes of that must be direct RN care. The rest of the minutes can be provided by enrolled nurses or personal care workers. And also, this only applies to the metro. It doesn't apply to regional, rural, and remote. They are exempt from the care minutes. And this is no doubt due to perhaps their limited capacity to have registered nurses or suitably qualified clinicians. So it is only relevant to the metro areas. The other thing, and there's some good guides, again, just to have a look, there's some great resources on the department's website in this space. So I encourage you to go and have a look at that. And Tim will share the slides with listeners. So you can just have a look in your own time. Obviously, there's a care minute supplement. So your funding is linked to delivery and compliance of the care minutes. So providers have to have in place, obviously, systems, and I would assume they do because they've had to collect this in the past. And also, if you go on to, any consumer can go onto the government website and have a look at residential care providers, and you can clearly see how many care minutes they provide per client. So, for example, when I was recently looking at having to put my mum in care, that was one of the things I was looking at. So it's readily available. You have to report on it, and there's really just now a requirement to have it increased, or it's been increased. So your funding is definitely linked to it, and you obviously have to report on it. You've got to report on it in your quarterly financial reports. And you also have to complete a performance statement. Now, my understanding with the performance statement is that this has to be done by an external registered auditing company. So, whilst you might collect the information internally, it is a requirement for this to be done by a registered auditor. I guess for me, looking at this, there's no real link between this and the standards. However, when you look at standard 3 and you look at standard 5, because it's all about clinical care, it obviously does speak to the importance of having, qualified, clinically trained personnel delivering appropriate care. So that's kind of where it links back, but the standards don't really speak to specifically the care minutes. So I think that's to be mindful. You have to meet it for compliancy and funding purposes, but your standards are really about ensuring that the right person, the right qualified person, delivers the right care. So, for example, in end of life, there are some tasks that a personal carer would undertake, and there are other tasks that would require a registered nurse to undertake. And it's providers just need to ensure they're really mindful of the differences. We talked recently, it was interesting, and people have different views around this, around, for example, emptying a catheter. Now, in a home care environment, a personal carer would do that task. In some thinking in residential care, and obviously in the acute sector, that's done by a trained nurse to do that. So, it's again around just understanding all your clinical procedures and who is the most appropriate person to undertake that task and what sort of training qualifications are needed. So really that's kind of how I guess the care minutes fit in with end of life and palliative care. I think for the most part, the care minutes, the 215 hours, does not change significantly at end of life or palliative care, because a lot of end of life care, a personal carer does deliver. There's some people require more clinical care at end of life, but others require minimal. I was speaking recently to a palliative care specialist who they go into country areas in Western Australia, and they openly say they probably provide 6% of clinical care to patients in the home. The rest is provided by personal carers and family. So when you think about your care minutes, and you think we're going to blow those out of the water or we're not going to meet them, you just need to think of those kind of scenarios where some will need more clinical care and other people will need less. That's me, done. There you go. Any questions, Tim?
Plenty, Catherine. So
Yes.
I forgot to acknowledge at the start, we had been pre-surveying people before today's presentation for both content development, but also to anticipate any questions that you may want Catherine to answer. And I've got a bunch. And the first one that I've read over and over in a lot of the survey responses is the intersect between specialist palliative care services and the support at home program. Can you clarify that for us, Catherine?
Yes, yeah. Look, it is it's a bit of a bugbear of mine, I've got to be honest, and it's something in the sector that people get really confused with. We tend to, as you know, we use, as I have done today, we use end of life and palliative care in the same sentence because there is a school of thought that anybody and everybody can provide palliative care. So there is also another school of thought that palliative care sits quite different to end of life care, and that it is a specialised field of care. Regardless of how you look at it, what we say is that specialist palliative care is delivered by a specialist palliative care service. They are clinically trained palliative care specialists, and most clients will have a connection at end of life with a specialist palliative care service. Not everyone will. Some people at end of life do not need or are not eligible for a specialist palliative care service. However, I say to providers, I think it's smart to have a relationship and to have a palliative care service on board, even if they're just checking in, even if they're not providing a substantial hands-on clinical role, because you don't know where things are going to go and you don't know what things are changing. There will be other clients, though, within the home care space that have significant palliative care needs that require a substantial amount of specialist palliative care input. And the end of life pathway is not designed to fund specialist palliative care services. It's designed to run in parallel. So, we're over here in the home care space doing our thing, and we're being supported by the palliative care specialist team. Does that answer that question, Tim?
I suppose as well, Catherine, what kind of services would they be providing as part of the support at home program that are different from a specialist palliative care service?
They're providing their clinical expertise. Again, I think we can't, in home care, they have a service list, as I mentioned in their manual. So there's this list of services that they are able to provide within the home care environment. Most of those, and in the end of life pathway, whatever services have been approved, that is all they can provide. So there is a significant number of services that you would have to go outside to a specialist organisation, palliative care or other, to provide because you're quite limited. The other thing is that home care providers differ considerably. There are some who have nurse practitioners on their staff. They have registered nurses who may have some palliative care training, but we see that as quite separate to being a specialist palliative care practitioner, which it is, and I think we've got to be realistic around that. I see a lot that the specialist palliative care team will manage complex symptom management, where a person is perhaps got quite complex needs. They need to be regularly assessed. Their symptoms need to be regularly managed. They are perhaps, not being well controlled at their end of life, and that would be out of the scope for most home care providers to manage. Um, but again, it's this is a very untested space, and I think it will be interesting to see um, how specialist palliative care services can work in partnership with the home care sector. As I said, there may be a few providers that possibly feel they can go it alone in this space. Um, I'm not convinced. I think, it's wise to have those partnerships and wise to have those relationships, but there'll be a lot of providers that cannot do this, absolutely cannot do this without a palliative care service working with them.
You mentioned earlier with the changes to the strength and aged care standards, there is a component in which they'll need to prove that they're communicating as a provider of an aged care service to palliative care service if need be. In the situation in which there is both a support home program funded service and a specialist palliative care service, what might that communication look like? Do they need to be aware of each other? Do they need to liaise regarding the care provided to that person? What's the responsibility in that space?
Yeah, certainly they have to. Part of, for example, activating the pathways, they must have an end of life pathway or an end of life plan and care plan. So really, that's got to involve all the needs of the person and their family, and who's going to provide that. So that that's where I would imagine we encourage providers to have already in that preparedness, already set up good relationships with their palliative care service, their local one, or whether it's a telehealth or whatever it looks like, to have those partnerships already in place. Formal partnerships are really encouraged, and to discuss what the pathway of referral is. We don't want to wait till someone is at end of life. We're activating the pathway and we're suddenly running around trying to get a palliative care service on board. That's actually what we're trying to involve, sort of avoid. We're trying to make sure they have those partnerships already in place, and as much as possible, a seamless referral process. Um, it may be that for some services, that's actually a hands-on referral where the service comes in and delivers, hands-on direct clinical care, or it could be where they're just providing advice and support to perhaps the nurse already in the service. I'm encouraging providers to have conversations and establish relationships that best suit the circumstances for them.
Mm. And can you walk me through a couple of hypothetical scenarios in which someone may access these increased level of services?
Yeah, so often I think the most at the moment, perhaps the most common and I think the easiest pathway is someone becomes very unwell. They're perhaps already in the home care environment. They become quite unwell. They end up in hospital. There's a diagnosis, a terminal diagnosis given, and there's some options of whether they go to hospice or they go to residential care or they go home for end of life. And so that then their wishes are to go home, and so that this process is activated. Why I say that's a slightly easier pathway is because normally from the acute sector, the referral is already made to a specialist palliative care service. The home care team's already familiar with the client and involved. Equipment often can be organised through that pathway. So things are kind of set up. So the person goes home and, everyone kind of knows what role they're playing and where they're at. So that's kind of a scenario I think is certainly most common in the home care environment at the moment, and what won't cause too much grief to anybody because it does work fairly well in most places. The other scenario is where you have someone who's clearly um, perhaps they're frail, they've got some complex medical conditions who end up becoming quite unwell, and it sort of tips them over the edge a little bit, and they just don't bounce back. And they've got GP involvement, home care's involved, and perhaps there's already a package, a level 4 package has already been assessed because their needs are changed. And clearly that person now is the provider might be starting to think, I think this person's actually, I think we've reached the end of our journey and this person's moving towards end of life. They're just, they're noticing those quite rapid declines and the person is not bouncing back. Now, that scenario is a little bit more harder to perhaps assess end of life. You're certainly assessing 3 months end of life is really quite problematic. And often, if a provider makes a referral to a palliative care service at that point in time, the person may not be eligible for different reasons. And I have heard sometimes that happens because of the vagueness of perhaps the person's decline. So, if someone has a brain tumour and they're given a certain time to live and they've come out of hospital for end of life at home, it's a little more obvious of what's going to happen and when it's going to happen. Doesn't always go to plan, but it's a little more obvious. Someone who's just really declined and there is a feeling that we're moving towards end of life, it's a lot harder sometimes for anyone to say we're going to start stepping in and increasing our service delivery. An example of that is that a personal example, my auntie recently is in aged care. She's been quite unwell over the last 3 to 4 months, multiple hospitalizations, huge declines, and we were called in last week because they really felt she'd taken a turn. She was at end of life. The priest came in, the family did the vigil. We're all gathered round the table. Had we done the Karnofsky, she would have scored way below 40. I would have thought she would have been end of life within a week. Her breathing, terrible. 3 days later, she was up having breakfast. You know, so it's really tricky. So sometimes things are done in a crisis, like they're done at the last minute. We make it, we get it wrong. But I guess it's why for me it's important providers have those relationships with the palliative care services. It's okay to say we thought we were there, but we're not. You know, because we are going to have those so that's kind of that other end of the scenario where it just does not go to plan. Um, and I think one more scenario which is really tough is the person who is just really frail, but is slowly declining. And they've possibly been in the service for years, and staff start to note things are really changing, but it's quite nondescript. That's hard to assess end of life. And, you know, I think the feeling is we possibly will leave it too late to activate the pathway. I think for most, the feeling in the sector is a bit around, I think rather than activate it and thinking we got 12 weeks, I think if anything, by the time we feel really confident, we might only have 3 weeks. That's kind of the feeling, but again, it'll be really, I guess, really interesting to see how it all evolves.
And when there's temporary admissions to hospital, is there are their fees frozen during that time?
Yes, they are. Yeah. So hospitalisations, basically no care is charged during that period, and they can resume it, upon entering the service. Now, the end of life pathway, it doesn't stipulate that. So we're interested to see, certainly in any home support package or level, that's the rule. We're assuming that's going to apply for the end of life pathway, but it hasn't been tested yet, Tim, to be honest. So, because that potentially could blow that, 12 weeks out to if a person's in hospital for a month, that type of thing.
Yeah,
So
yeah.
I'm assuming the same rule applies, but it's not specifically written in the end of life pathway rules.
And is there any regulation around what service providers can charge?
There is parameters around that, and the service providers at the moment are going through that process of working out what they will be charging. The end of life pathway, so there is a mentioned case management or care management. There is a cap in normal funding of 10%. You cannot charge more than 10% for care management. Within the end of life pathway, that's open, there's no cap, because they realise there could be a lot more coordination and collaboration that a person has to do at end of life. However, it has to be reasonable. So it's got to be that it can't be 80% and 20% is care. That's actually not going to work. So as long as it's reasonable, they can charge a bit more for care management. Um, Under the new supported home rules, most people now, or people sort of entering the aged care sector, have to pay a co-payment. That hasn't been required in the past. So certainly even one, it was if you were obviously asset tested, but this is separate to that. So again, that applies for end of life. So that's going to be interesting and tricky around asking people to provide a co-payment now for services that in the past were provided free of charge. So, or covered by the funding. So that's another little tricky area for providers. And providers must publish. I'm not sure what the date is, but it's coming up soon. They have to a certain point in time where they must have, or I think it's actually coming before the end of the year, they must have all the prices published on their website.
It's good, good.
Yeah. So it gives people a good idea and look, the end of life funding, it's slightly more than the old level 4 package, which was about $69,000 a year, and this is 25,000 over, sort of 12 weeks. You can do the maths, but it's not a lot of money. When you think about it, you're not going to be able to purchase in a carer to spend all night with the person or anything like that. You'd run out of funds very, very quickly. So you'll find a lot of people that are even on a level 4, if they have a carer coming in twice a day, 7 days a week, they've got no money left. That just gives you an indication of the money doesn't go that far.
Yeah, I was going to ask as well, Catherine. Obviously, a palliative approach is all about creating a person-centered care. And you'd hope in circumstances in which there's a predicted decline, you'd already be having advanced care planning conversations beforehand. But as someone who's on the end of life care pathway, how can it be ensured that the person is receiving care that they would actually want to receive?
Yeah, that within the rules, they have to have an end of life care plan, and to be accepted onto the pathway, they have to have that care plan in place. It has to be really clear about what services are going to be provided, and once that's assessed and agreed upon, the provider must provide those services. The flip side of that, which isn't good, is that if they want to provide other services that haven't been approved, they're kind of stuck between a rock and a hard place. So it does protect, it's great because it protects the person around receiving the services that they've, entitled to. But the other side is that, say, if their needs changed and you wanted to introduce something else, you would have to go back and get approval for that. So that's the flip side of not having that flexibility once the services are approved and agreed upon.
And what documents would they be completing, Catherine?
They're required, as in now, they're required to do a comprehensive care plan, and they have to have that in place anyway in home care, which is actually, part of the assessment process. And now they will also have to have an end of life care plan with all the services that will go through the My Aged Care assessment process and be approved. So it's not dissimilar to the process that the previous ACAT assessments, that are done and looking at all the domains, all the needs of the person. It is quite a comprehensive tool.
Are there any misconceptions that you'd like to clear up?
Look, I think no, look, not really. I think the main thing is just around it doesn't replace specialist palliative care. I think that's really want to make that clear. I come from a nursing and a palliative care background. I consider it to be a specialist form of practice, and I think it's we're trying to educate providers around the fact there is a need to work in partnership with our specialist palliative care clinicians and practitioners. We can't do this on our own. We've got to do it in partnership. We can provide a certain amount of care, but we need their support and some direct care as well. So I think that's one of the really key things is don't be kind of fooled by the language around using palliative care. I think it I think it really confuses people. I've argued for end of life and palliative care, with palliative care being recognised as separate and specialist. But the argument is out there, and as I said, there's a school of thought that we can all do palliative care. I'll leave that one for you guys to all have a think about.
All right, Catherine, thank you so much for your time. Anything that you have referenced throughout today, whether it's the assessment tools, whether it is the LDAC resources, they will be included in the show notes. And thank you very much for also sharing the slide deck as well. That'll also be included in there. Is there anything else you'd like to say before we wrap things up?
No, look, I just thank you very much for having me. I'm always happy to answer, obviously, any questions. I'm also happy for you to provide my email address, Tim, because if providers or clinicians have any questions in this space, if I can't help them, I have some great colleagues in Ageing Australia who certainly know a lot more about residential care and some of the changes than I do. My space is really more home care. But I can always put them onto the right people, and we've got some really good experts in this space to answer their questions.
Wonderful. Thank you again so much for your time, Catherine.
Thanks, Tim. Thanks for having me.
And where's stop? It is done. That was fantastic.